Dr. Moses has educated above all of us, being a professor for Temple at both law and medicine with the JD and DO. Just transitioned a new part of his life within the past year at Eli Lilly, serving on their board in multiple consulting roles. We welcome you all the way back from Philadelphia 2 years after you made such a strong impression. Thank you for speaking with us on this.
Thank you very much, Chuck. So this talk was strategically placed by Chuck and Lewis at 4:30 for the sole reason that the last time I gave a talk here, everybody wanted a drink. So we are primely positioned for cocktail hour. So I and the panel are standing in between you and that. So with that, let's get started. Here we go with my pointer. So, yeah, I suspect it's like me doing a 4 o'clock Zoom call. Cocktail hour starts early. So, first of all, I have no conflicts of interest or anything to disclose. I'm relatively boring in that aspect. Our talk, the title is a little bit confusing, but this last year and a half has been a little bit confusing. This is the first live presentation that I'm giving in 18 months. It's the first time that I've had a collared shirt on, I think, in about 18 months. But when Chuck called, Lewis called, I'm right back down to Texas because I just love it here. So what we're really going to try to do is I'm going to try to bring you up to speed on what has gone on in about the last year and a half and where things are moving forward when it comes to telemedicine in the post-COVID pandemic, understand the potential impact of the 21st Century Cures Act, and I will differentiate that from the CARES Act. We'll identify the significance of open notes access, which is extremely important. Identify the potential evolving medical professional liability risk areas, some things we've reviewed in the past, and how what has gone on will now apply potentially in the future. And then I'm going to, as usual, try to give you some defense and other risk management strategies, because I just want to reiterate, we all know that I'm a 100% defense person, and that is the arena that I play in. So with that, these are the different sections of our talk. You can read it for yourself. Let's just jump into telemedicine. So by way of some definitions, telehealth refers to the broad scope of remote healthcare services that includes non-clinical services, whereas telemedicine involves specifically remote clinical services that a healthcare provider will provide through some type of an electronic platform to a patient who's at a distant site. And these definitions will vary from state to state through different organizations. This is nothing new. The American Telemedicine Association has been around for almost 30 years. They're a nonprofit group that's been trying to get medical information over an electronic platform for decades. And they have been very aggressive in the past. COVID has really put them on the launching pad. The government is no stranger to telemedicine. They never really embraced it. The High-Tech Act of 2009 set out electronic platforms, was really focused on electronic healthcare records. PPACA and MACRA, two laws that we're both extremely familiar with for a number of reasons, did embrace telemedicine, albeit not particularly seriously. CMS did dip their little toe into the water with regard to telecommunications, and they established a list of reimbursable services. They were very limited. They outlined a few originating sites, again, limiting what could be, and exactly what services they would provide across telemedicine, with the goal of making healthcare more available to the Medicaid population and to more rural areas. And this did not really take off. I mean, everybody in this room will admit that dating back to 2015, none of us really got involved in telemedicine. And there's a number of reasons for that, which I'm going to go into. However, something happened. COVID happened. the COVID pandemic happened. And Lewis went into a really eloquent description of what was going on in November and then in December in China and in some of the Asian countries. But it wasn't until January 21st of 2020 that the first case of SARS-CoV-2 was identified in the United States. And that changed everything. Okay, I lived through that. It put an extreme burden on the healthcare system. In addition to the world, it shut down medical practice. We saw some data from Dave today about how colorectal cancer screening, screening for gastric cancer, treatment for cancer came to a grinding halt. My practice came to a grinding halt. No one knew what to do. Healthcare was not being delivered. You know, we're still suffering the consequences of COVID. And, you know, I even question whether the COVID pandemic is behind us or is not behind us with the Delta variant. But so I digress. So let's talk about what this did. Okay, what it did was have President Trump to declare a national emergency. And by declaring a national emergency, it allowed the Secretary of HHS to invoke Section 319 of the Public Health Emergency Act. And what that did was to then allow the 1135 waiver of the Social Security Act. So what is the 1135 waiver of the Social Security Act? By the way, there's no test after this. Very important information. But I just want you, you know, we all need to understand what happened, right? Because one day we woke up and the next thing you know, we're trying to figure out how we're going to communicate with our patients over something like a cell phone. What about HIPAA? You know, what about privacy? Who's going to pay for this, right? Because what was the main reason that none of us really embraced telemedicine? One, they didn't pay for it. Two, we weren't going to get paid for it. Three, no one was going to reimburse us for it. Okay. Four, we were worried about HIPAA. And five, there was no platform or any need for it. Okay. So, I mean, this is what was going on. But the 1135 waiver allows the Secretary of HHS to bend the rules with Medicare and Medicaid, which is exactly what happened. So that on March 6, 2020, restrictions were lifted with regard to telemedicine delivery and reimbursement. Recall, I told you that MACRA 2015, CMS dipped their little toe into it. Well, now they jumped in head first because Medicare, Medicaid patients were not getting health care provided, and CHIP patients, the children. So what this basically did was permitted telehealth services for physicians, nurse practitioners, et cetera. And the one group that I have here is our chiropractors. So chiropractors, I'm not kidding, were also allowed to provide telehealth services. Now, try to get your head around this legislation and what our government was trying to do, because I can understand how a healthcare provider could provide telemedicine services. I will share a story with you at the end if you remind me. We'll see if you're paying attention of my experience with making a keen diagnosis on teleservices. But if you're a chiropractor, what are you going to do? I mean, you say to the patient, like, well, yeah, put your hand in the back a little bit more and kind of rub over here. I mean, to me, that made no sense. But it did at least provide some form of health care to a number of healthcare providers. Okay, so there were a number of laws that were proposed throughout 2020 to try to deal with the pandemic and to deliver healthcare services. Most of them went by the wayside. Because as with many things with the government, when they put a bill out there, it's loaded with a bunch of extra juicy stuff that has absolutely nothing to do with the issue. In addition, the state laws regulate telemedicine. So it was a sticky wicket to try to get something that was usable passed. But fortunately, HR 366, which was bipartisan supported and signed by President Trump, it was one of his last pieces of legislation on January 19, 2020, was signed into effect with the goal to safeguard access to virtual care after COVID-19. So telemedicine was such a success that there was this move to try to move it into perpetuity. In other words, to be able to provide telemedicine services after the COVID pandemic settled down. And in fact, many practices are still providing teleservices. Now, Lewis showed you data today, I think, from the Texas Society of Gastrointestinal Endoscopy poll that said 19%, he said, of you, so I'm assuming this group, are basically using telemedicine. Really a much lower number than we were seeing last year. Carol Burke shared that 75% of her practice is a virtual visit. Okay, so depending on your specialty and depending upon what part of the country you're in, depends upon what degree of telemedicine, what degree of your services, your medical services, are being provided on a telemedicine platform. So I told you the three reasons that out of the 5 that we were not getting, that telemedicine wasn't really adapted, was lack of reimbursement, and lack of reimbursement. And I don't know about your experience in Texas, but despite the national emergency and the waiver 135, 1135, despite that, in the Pennsylvania area, and I know we're a tri-state area, so I have a pretty good idea of what goes on in Pennsylvania, New Jersey, and Delaware. Even though we were getting reimbursed for Medicare patients and Medicaid patients, I don't do pediatrics, and CHIP patients, we were not seeing any dollars from any of the private insurers. And I know, and I'm not calling out anyone in particular because I'm an equal opportunity insurance company hater, just saying that United, Aetna, and Cigna gave major pushback and were reimbursing pennies on the dollar because there were existing telehealth or telemedicine codes out there. In our area, the first insurer, now I'm talking private insurer, okay, commercial insurer, that rolled over and actually paid a substantial fee was Independence Blue Cross. Okay, eventually a number of the other insurance companies came around. Some of them still held out. So why am I telling you this and why am I sharing this? This is because there are no parity laws in Pennsylvania when it comes to private insurers. So what are parity laws? And this is also one of the reasons why a number of the federal bills didn't move forward, okay? Because they tried to regulate the states and parity laws, but these are state enacted laws. And parity laws are basically laws that require private insurers to cover telemedicine. Okay, so by the way, I wanted to say that one of the things that the waiver 1135 did was allow Medicare to reimburse at a rate as if you would have done a like 99214, 99213 visit, the physical exam, right? Because, you know, that's another thing, another reason why I was always kind of like funny about telemedicine, because any of you that were around, I mean, you know, that were trained, you know, up until maybe last year. I mean, the concept of not putting your hands on somebody and physically examining them is unheard of, right? I mean, it would be like unbelievable, right? You talk to the patient, you touch the patient, you examine them, right? So telemedicine completely takes that out of the formula. And you know that our reimbursement codes are based on partly physical exam. Right? So that's what the 1135 waiver did. Well, parity laws didn't exist, and they still don't exist. There's no federal mandate for it, but this is why we weren't getting paid and why the private insurance companies didn't have to really step to the plate. We're going to skip over that. Oh, sorry, we're going backwards. We're going to skip that. We said that. All right. So that really kind of gives us where we are in telemedicine, okay, right now. So telemedicine, I believe, is here to stay. I think it's going to have a role. I will share with you that depending on your specialty, some specialties embrace telemedicine more than others. It's very popular in psychiatry. I just read a paper that actually did a survey for hepatologists. Hepatologists find it very helpful, particularly for monitoring their liver transplant patients. Endocrinologists feel that it really helps them with their type 2 diabetics. So I really want to start to move this along a little bit. I want to talk about the 21st Century Cures Act and open notes, because this is an area that is really hot right now. This is the third presentation that I'm giving mentioning this. It's a potential for liability in the future. So the Cures Act is not the CARES Act. The CARES Act, as Lewis also alluded to this morning, was a $2.2 trillion coronavirus aid relief and economic security act. And basically, it was passed by the 116th Congress, signed into law on March 27th by then President Trump in response to the economic fallout. And it addressed a number of issues, particularly telehealth. And what the CARES Act did was lift a number of restrictions in telemedicine to make it easier to provide services. So remember that previously we had to be HIPAA compliant with the platform, an electronic platform. Telemedicine was a hassle. Now I'm providing telemedicine services over my cell phone, okay, or over doxy.me. All of these platforms have popped up. I was providing telemedicine services in the beginning over a Zoom call with a patient. So this is one of the things that the CARES Act helped to do. It also lifted up a number of restrictions. So we were now allowed to prescribe narcotics with some restrictions utilizing telemedicine, which previously, because of the opioid epidemic, was not permitted, as long as you followed whatever the state regulations were. And it also increased the funding and the flexibility with where the service could be provided. This is different than the 21st Century Cures Act. So the 21st Century Cures Act came out of an initiative that started in January 2016 that then President Obama gave then Vice President Biden the responsibility of trying to figure out what could be done to help expedite curing cancer after his son, Beau, passed away of a glioblastoma in May of 2015. And things went along, but ultimately the last piece of legislation that President Obama signed into law on December 13, 2016 was the Cures Act. And the Cures Act basically did a number of things to expedite drugs and devices coming to market. It did a number of things with our clinical studies, but like with anything else with the federal government, you've got to read the fine print. The devil's in the details. In the Cures Act is a section called the Information Blocking Regulation, which has now been has become known as the Open Notes Rule. And the goal was to expand transparency and interoperability. Recall, we as physicians, one of the biggest problems we had was interoperability, right? So you're at Mount Sinai, okay? The patient was visiting relatives in Philadelphia, went to Jefferson Health, was seen in the ED, lives in New York, now goes to Mount Sinai, gets sick again. He's in his internist's office. The internist can't get those records from the ED at Jefferson Health. Lack of interoperability. So the Cures Act, the government's, the legislators slipped this into the Cures Act. All right. So it was supposed to take effect in December of last year. COVID, the pandemic, pushed it to April 5th, 2021. So this is in effect now, and it identifies categories in the clinical notes that are entered, created, or stored in your electronic records. If you're still living in the prehistoric era and you're using paper charts, this doesn't apply to you. I will bet you dollars to donuts there's no one here in gastroenterology who's using paper charts. And basically, what this requires is that healthcare providers have to give patients access without charge to their electronic healthcare records without delay. AKA immediately when I ask for it. The standard is no longer within a reasonable amount of time. Okay, it is immediate, which raises a number of issues which I will share with you. And this has really created a clamor in the medical malpractice defense insurance world and with medical malpractice defense attorneys. There are a number, open notes rule outlines a number of areas that are mandatory that have to be made available. I'm not going to go into the detail. There's no surprise here. It's our H&Ps, our lab reports, path reports, etc. You know, this is here for you. It's probably everything in your chart. There are some exemptions, anything that's reasonably anticipated for criminal, administrative, or civil actions. Psychotherapy session notes, however, may come in depending on what the note has in it. You are now allowed to list psychiatric diagnoses and medications when the patient was seen, but still there is redactable material. Important. Just as the Cures Act is not the CARES Act, the Open Notes rule is not opennotes.org. Opennotes.org is a nonprofit organization. It was a project that is over 10 years old between a consortium of Harborview Health, which is the safety net hospital for the state of Washington's medical school and health system, with Beth Israel Deaconess in Boston, and with Geisinger Health System in Pennsylvania, with the idea that they had this idea that providing patients with open notes so that they could see everything in their chart without requesting would improve healthcare. And they've been pushing this for now over 10 years. They've done a lot of research. They have a lot of money and a lot of backing. Their initial backing was from, I think, the Robert Wood Johnson's Foundation. They were given $10 million. Okay. But they're creating a lot of information. They have nothing to do with the Open Notes rule. Okay. However, and vice versa. However, they do have a lot of experience and they do provide free of charge advice and interpretation with the Open Notes rule. So, you can log in, you don't have to pay any money, and you can do a live chat with somebody who's in the Open Notes, in opennotes.org. Okay. They have created a number of studies. So this was just one interesting study that I'm going to share. This was with a number of primary healthcare providers. It was a survey that was done online, and they sent it out to, I believe they sent out, I think, 6,800 requests. They got roughly 1,700 participant replies. And one of the questions they asked was, do you think the statement, would you agree that making visit notes available to patients is a good idea? And if you look at the bar graphs on the left, you can see that the majority of the respondents, being PCPs, specialists in the light blue, that's us, yes, the specialists, and advanced practice providers, all thought that this was a really good idea to provide open notes. Now, realize that this is a population from those three organizations. So I think that they may be a little bit tainted, but the point is that these are practitioners who have been doing this for like the last 6 to 10 years, and they felt that it was widely accepted. All right, so I want to jump a little bit, and I want to give you some medical liability insights. Okay, so let's see where we are here. Some of this you've heard in the past. Some of it is an iteration and looking forward and forward thinking. So this is, I love this. This is a 2019 Medscape, this is from the 2019 Medscape malpractice report. This was a survey of 4,300 physicians across 29 specialties, looking for the top 10 reasons why they were sued, why they were involved in a medical malpractice case, if they were. And I want you to keep these reasons in mind because it all goes back to that immediate availability because of the Open Notes rule that patients have to see their records. So the number 2 reason was poor documentation of patient instruction and education. So this was another survey. This was done by the MedStar Foundation from MedStar Health, which is the foundation's a multi-million-dollar funded foundation that does medical research, is very interested in patient safety. They're an offshoot of MedStar Health in Washington, D.C. And basically, they were looking at EHR and the increased risk of liability of electronic healthcare records. And they basically were looking for usability problems of EHR to try to get 7 categories that they could identify to call to the attention of their providers. Data entry was the number one problem that they found. Faulty data entry. Okay, interoperability was number 3. This is a study by the Doctors Company. So the Doctors Company is a medical malpractice company. They insure the most number of physicians across the United States. They started out in the California area, California, Washington, and they're really big up in the Northwest. And they basically analyzed data from 80,000 of their members. And they reviewed basically the plaintiff allegation. Remember, plaintiff are the ones that sue you. The defendants are the ones that defend. Think of a word like a PR word maybe, and plaintiff, and that's a great acronym. But we'll share that offline because we're getting taped. But basically, they analyzed this data, and they looked at different reasons why physicians were sued. And they basically compared closed claim data over a 7.5-year period and a 2.5-year period. And I thought this was interesting, and it just goes to show you the impact of electronic healthcare records. So study number 1 is the look back from 2007 to half of 2014. They found 97 records with claims in them. Okay, 97 records. However, in only a 2.5-year period, they were 2/3 of the way there. So this is almost like a no-duh study. Okay, obviously, now that we're moving into electronic healthcare records, we're going to see more liability with electronic healthcare records. Okay, so where do we get into trouble? What do we have to do? All right, so documenting has never become more important. Okay, you need to document your decisions, and you need to document your discussions with your patients. Copy and pasting. We've all heard about this, copy paste, don't copy paste, don't copy paste. Yet electronic records were made to copy paste. The problem is, in particular, when there's an error, right? Because you're copy and pasting the error. So in the past, and and you've heard me lecture on, I've presented to you on electronic healthcare records, so you know where I come down with documentation and EHR, okay? If you're in a training program and you're training residents and fellows, you know that it's just a parrot of what is up there. But there is more pressure, in my opinion now, to understand and fix errors, because you're going to be showing a potential error to a patient and anybody else they want to show those records to real time. And I will tell you, I will share with you, as I have before, that what happened doesn't matter. The plaintiff attorney, all they want to do is make a story. And the facts of the case become absolutely irrelevant for what they want to sell to the jury at a 3rd grade level. So you must fix errors. So copy paste is really, is really of concern. And then obviously documenting any type of interaction. If you get emailed and it's not through your portal, if you get texted, you've got to document that. This is from Crico. So Crico is a med mal insurance company that basically started, it was a self-insured from Harvard, and now the New England healthcare system. So they basically looked back a few years ago, and they realized from their database, which was rather large, that 55% of their medical malpractice cases involved inadequate provider-patient Communication. Here we go with communication again, right? These were concerns raised by CRICO that opening up clinical notes to patient creates a potential for increased miscommunication. Why? Why is that? Because patients don't really get it. They don't understand the medical jargon. They understand Google, right? They understand Wikipedia, or they understand some blog from some whoever, all right, or some, if they're doing social media, some influencer who may be, and I'm not picking on chiropractors, but, there's a chiropractor out there who's an anti-vaxxer, and he's out there like he's a doctor, scary. So patients really don't know what they're looking at. Some of the notes may not be accurate, thorough. The contemporaneous charting is now critical. Your tone, tenor, and sensitivity on what you write is important because of what can be read in between. I'm going to share some interesting recommendations. This is the Cures Act. I don't think, yes. This is great. This is a great study. So this is from Open Notes, okay? This was a qualitative study, okay, that they recently published. It looked at encounter notes, electronic healthcare record encounter notes, 600 encounter notes from 138 physicians, all right? Their goal was to identify linguistic characteristics in the notes that reflected the overall attitude of the provider, the doctor, you, towards their patient. And they identified certain themes that came off negatively in the note versus positively in the note. So what were some negative things? Now, think about your notes and think about notes of other physicians that you've read. Okay, because I read a lot of notes because I see a lot of notes that come to me for a potential this or a potential that. So what's negative? Questioning the patient's credibility. Did they take their medicine? Why didn't they do what I said? Expressing disapproval of patient reasoning or self-care. Well, I read on Google. Stereotyping by race or social class, portraying the patient as difficult. I looked at a note of a malpractice case of a very well-known, nationally known motility doc of a patient who was seeing a patient with horrible refractory gastroparesis and has seen 3 other gastroenterologists at major institutions. There was a med mal case because he had the patient on Reglan more than 12 weeks, as many of us do. And the patient had a reaction. So, I forget who mentioned the billboard when they were driving down here, but yes, there's a class action on Reglan. But in the notes, it said, I'm going to change the name. Bertha came in today to complain of her nausea. Oi. Okay. And oi was in 3 consecutive notes before she stopped seeing him because she felt that he wasn't attentive to her. All in the notes, okay? Negative, okay? And emphasizing your authority. I'm going to wrap this up in a minute because I'm a little bit over. I apologize. Positive things, direct compliments, expressions of approval, self-disclosure that you have positive feelings. I'm happy with the way the patient's doing. Minimizing blame, personalizing the note, highlighting the authority of the patient, and working with them to make their own decisions. So there are 2 recurrent themes when we talk about liability: communication and documentation. The days of the doctor saying to his staff, please delete all my snide remarks, and then make a copy of the patient's chart and give it to her, are gone. Bye-bye. All right, let's wrap this up with some risk management ideas, okay? So, if it's at all possible, review all the available data and information prior to going in to see the patient. I know this is hard, but if you know what's going on ahead of time and don't try to read the note while you're there with the patient, you're going to be ahead of the game. Adhere to alerts when you're prescribing. We know that. Beware of alert fatigue. I told you about cutting and pasting. Make sure that your documentation is relevant, objective, and current, okay? Fix any errors because you don't want something that's just incorrect to get out there in front of anybody. Don't forget metadata. I've told you this before. Everything in your note is tracked. Every change is tracked. Now more than ever, if you give your patient a chart, you weren't going to make a change before, you absolutely don't want to make any changes or additions now unless you mark it as an addendum or correction of an error, and you are transparent about that, okay? If you do that, that's a lot easier to defend than you going back and saying, oh, you know, I just made a mistake. I could have had a V8. Let's see. You know all this. Okay, so this is from Crico. I'm going to wrap it up with this, and I will share. I'm not 100% sure what the big deal is with open notes. Patients were always allowed to get copies of their records, paper, long before EHR, and EHR. It's just a standard change, puts a little more pressure on us. You have to avoid putting things in the note that would insult patients. You've got to use your common sense, okay? I'm surprised at some of the charts I've read of docs where I'm thinking to myself, like, dude, what were you thinking, okay? If a patient weighs 400 pounds, don't call him fat, okay? Fat doesn't do it, okay? They have an elevated BMI, okay? If the patient stinks of body odor because they're unkempt, state that they're poorly groomed, okay? It doesn't matter that you're spraying the room with air freshener afterwards, okay? And never criticize another physician. Absolutely not, no matter how you feel. Let's see. If the patient's a jerk, don't say that they're a jerk, okay? If they insult you or they're demanding, just say they're demanding. Say, you know, and if there was a negative interaction with the staff, just say, patient came in screaming my office staff. We had a discussion. I explained to them that that's intolerable behavior. It's okay, okay? But they're a jerk. When it comes to sexual identity, anything controversial, lay off your personal opinions, okay? Society's changing. Healthcare's changing. You went to medical school in order to be objective, okay? What you believe personally has nothing to do with who you treat, what you treat, or how you treat them. And remember, as the examples that I gave you of positive and negative linguistics, wordsmithing is our friend. So in summary, I tried to give you a number of things that have happened over the last 18 months since I have been out of a tie and out of a collar shirt. And I was restricted from coming to Texas last year to visit everyone. And I'm hoping that I will possibly be back next year, as long as I can do a nonstop flight, Jay. And with that, I just want to thank everybody. I want to thank everybody here. I love Texas. I love this society. I wish that I could belong.
Don't you belong? You can join. We'll take your dues. Do we get to hear the key diagnosis that you did, or is that later? That's at the party. You talk about it at the party.
Right after we go with telemedicine, when docs see me. So a nurse calls me up and says, will you see my son? I said, well, I have to do it virtually. So he calls me on his cell phone, and he tells me that he's in Maryland on his parents' sailboat over the weekend, and he pigged out on like hot crabs and beer. And he's got this like bloated, and he's constipated, and he's got this lower abdominal pain. So I'm like, all right, where is it? Not localized. I go, okay, I want you to take your cell phone, and I want you to hold it up to your stomach, and I want you to start mashing around. He was mashing around, he doesn't feel anything. So I said, I want you to lay down. So he lays on the floor, and he's pressing, and he goes, yeah, it kind of hurts down here. No problem. Go to the ED. So I called the ED. I said, I think this kid's got appendicitis. He has a white count of 14,000. They do a CT. He's got not a rupture, but an inflamed appendix. Unbelievable. Fast forward, a month ago, on my first outdoor event in 17 months, at a wedding of his now sister-in-law, I am a god.
All right, everybody. We're going to have our last panel discussion. We have a practice management panel discussion. Please come forward if you're on the panel. That includes you, Dr. Moses, please. Dr. Jay Puri, who's a partner of Digestive Health Associates of Texas, as we all know, and an executive committee member for that organization. We have Dr. Harish Gagnesha, who's a past president of TSGE and is in Austin Gastro. And then Dr. Chuck Owen, who's a co-director of this course, also has an MBA and an economist. So the topic, yes. Right, perils of the practice in the post-COVID era or in the current COVID era. Is that correct?
Maybe.
All right, everybody. Feel free to ask any questions. I don't have any way of getting questions from the virtual. Do we have that set up? Lise? All right, everybody. So I'm going to start with Dr. Gagnesha and just ask him to start this discussion. As it relates to COVID and the practice of medicine in terms of practice models and the structure of our medical groups and how that's affecting everything, please.
You are talking about the consolidation part of practice? Okay, all right. So there has been, before COVID, pre-COVID, consolidation, as you know, had started. First deal happened in 2015 or 2016, and it was accelerating. And just before COVID, quite a few deals were going to happen, didn't happen. And then during COVID, everything just slowed down, everything shut down. Post-COVID, in my opinion, the deal flow has accelerated than even prior to COVID.
Mm-hmm. Yeah, what do you think the main driver for this consolidation is?
I think there's insecurity is one part of it. Yeah, that's a big part of it.
Yeah, I mean, I think, I'm often asked by friends and colleagues across the country about, as their groups start to explore the potential for bringing on or joining an existing private equity-backed GI platform or maybe starting their own. And I think I encourage all of them to look at their own, because all business is local, and they have to look at their own, what I call existential threats, and make that analysis. Harish is right. The pace of consolidation has, and the clarification of the large private equity based platforms that are the drivers of consolidation being essentially regional, other than the largest, one of the larger ones, GI Alliance. The rest tend to be regional for the most part. And so I think that's the other thing that we've seen since COVID, as this trend has continued and accelerated, that there's been clarification and kind of a thinning of the ranks, and that the strongest have survived, and that tends to be based on the regions, if for anything else.
Dr. Owen?
Full disclosure, I was on the board meeting that voted for our capitalization partner. That being said, I don't know if it's an inexorable trend, pretty strong trend. I think Jay stated it perfectly. The events have pushed people and their confidence in doing this. And I don't know if it's security of their practice. I don't know if it's viability. I think a lot of it is frank collegiality. So that's why, but whatever the case, it was a pause that we saw within GI Alliance for about 6 months, and then it was a hyperbolic acceleration. So I think the way Jay said it is great. That's not a reflection on any of the groups. With all of these decisions that have been generated over the past 18 months, our confidence levels in certain things dramatically changed. And some for risk averse, but some for risk embracing.
You know, it's 3 of the 4 panel members are now in GI Alliance. So that'd be.
Can I add something?
Yeah,
I
sure.
think, one of the things COVID's shown is it's been the stress test of our lifetimes, other than a major war. And so, to Chuck's point, and to Harish's point, the fear that was latent and the insecurity, COVID definitely amplified that. And I think if there were groups that may have been on the fence before and maybe not sure, I think that's the other trend I've seen, that there are groups that maybe pre-COVID were not really sure. Those that are more fearful definitely have gone the route.
Yeah.
So, Louis, I get phone calls from around the country from people who never even thought of that they will be going into the capitalization route. A lot of people I never thought of you because you were totally strongly opposed it. Now even people like that are considering it, calling me, figuring it out. So I don't know what's driving that, but it's really accelerating.
Yeah, what I would say about that myself, my perspective is that you're right. All of you mentioned the powerful psychological component, and there has been a significant stress on the psyche of physicians and providers around the country. I think that's having a very significant impact. For some reason, physicians have lost the confidence in their practices. And I think that's a very important part. So a lot of the stated reasons that people give for going into employment models or hospital systems or in MSO are one thing, but the real reasons, a lot of them are psychological. You mentioned the way groups work together. So I think you used the word collegiality. I'm not sure what you meant by that. What does that mean? Herding? Does that mean?
It's not meant in a pejorative way. It is that some security can come about not only by collaboration on a professional level, but also collaboration for a future goal that could involve practice security, practice excellence, stated excellence then translating into payer contracts as pay performance comes up. It all converged. It was one of those things that Richard Neustadt talks about in American President. The effective ones have a certain window to put policy, and this window for consolidation was opened up in a very timely manner by COVID because it had been starting to accelerate anyways. But we reached an inflection point that now has become more hyperbolic. I thought it was going to be more asymptotic. It actually has become more hyperbolic.
So I have a little bit. So I have a little bit of a different perspective from background in watching this. This COVID made it the perfect storm because there was already a consolidation that started in Pennsylvania, in a number of the states across the country. And what was the reason for that? So we have increasing regulation from the government. We have increasing empowerment by insurance companies. We have a decreasing profit margin. We have a younger population of trainees that just want, like, I'm going to call it a 9-to-5 job, even though it's not a 9-to-5 job, but they want their protected time, which you don't get necessarily in a private practice where you have to, you get to bill what you see. Okay. Realizing that, if you're in an employment model, you have RVUs and it's different, but that's not the mindset. And then COVID comes along and shows practices how volatile we are as far as generating an income and how you can get shut down. And I think that one of the advantages that anybody who was on the fence realized with the private equity model is that there was a feeling that, one, there's safety in numbers. 2, we may be able to maximize profit margin by getting better better pricing for things like PPE, which I got to tell you, I didn't even know what PPE was. Yeah, I had no idea. But we, like my practice, we had trouble getting masks. And I have colleagues who their MSO had stockpiled masks, not because they anticipated COVID, just because they got some great deal on like 10,000 masks. So that's what they did. Compliance, you can have a single compliance officer. So I think it was a number of factors. And then I agree that COVID just freaked everybody out. And that's what really was the big push.
I think that when you talk about fear and everything, there's no question that risk avoidance is a serious business problem for physicians. There is no way to succeed in business or in practice or in anything without taking risk. And frankly, a lot of doctors are trying to avoid risk at all cost. And I do think that there's going to be a leveling out of that. There's going to be some extreme opportunities for success. All of those are going to involve some kind of risk. And there's going to be extreme opportunities for failure. We mentioned earlier, the statistics show that the ones that lost the most money during COVID were solo practice doctors. And they were much more likely. Hospital employed physicians made more money. So this is the first time that that's been flipped around in the economic history of practice of medicine, as far as I know, assuming it's probably going to go back. But that's very interesting. Dr. Haveman, do you have a question for the panel?
Yeah, a quick comment. I think, regardless of how much worse or better this virus has gone than people originally thought, I think it's pretty humbling to see $2.2 trillion of U.S. debt to keep us whole. That's humbling, and that's got to compete for some people, especially those smaller practices, against your very inspirational anti-fragility message. I think that's out there. That's palpable. I have a question about telemedicine liability. I'm seeing patients now that are in Florida, New York, and Bagram Air Base, not anymore, and all over, even other countries. Any comment on liability risks of that, or if I am doing telemedicine while I'm in another state?
So you're licensed in Texas, right? And where do the patients reside?
Florida, Kentucky, Colorado.
So have you talked with your practice attorney?
No.
All right. So okay. So no problem. Why don't we talk about this offline?
Oh my. Does anybody else have a comment about telemedicine experience? I will say that the survey that we showed was the ACG practice management survey as it relates to the endoscopy resumption task force. And it showed that between, at the beginning of the pandemic in April and in June, the number of responders who said they were doing 75% or more of their encounters by telemedicine dropped dramatically from about 70% to 19% during that time. And there have been a number of other surveys that have continued to show that kind of trend. And that's nationwide. And that was interesting to hear Dr. Burke mentioned that earlier, that most of her practice is telemedicine. How's that going for y'all, and what are your plans for the future?
I'll start. When COVID hit, most of my practice was 75% was telemedicine only. Slowly, number coming down. Now I'm doing about 15 to 20% of my practice telemedicine. I do mostly my IBS patients who wants to talk to me a lot more than being examined. IBD patients, some of the drug refills, some of the post-procedure follow-ups, and some of the screening colonoscopies. Patients are very happy to come to the office. In future, if the reimbursements stay the way it is, I plan on continuing telemedicine about 20% of my practice.
Yeah, that's a big if, right? But let's get real. How many of the times that you get on a telemedicine call do you then have to schedule a face-to-face call? A visit. And how many times is your telemedicine visit then transferred over to telephone only because of technical problems?
So patient selection is very important when you're doing anybody who even talks about a rectal symptom. They never get a televisit in my office. Not going to happen. So stuff like that. I think patient selection is the most important part.
Okay. So you have a process in your practice in place that somebody's been trained in the scheduling department that if someone calls in with a rectal problem,
Yeah, they're not going to get television. Yeah.
that's going to be, if somebody calls in, and says, I have diarrhea, about 25% of the time they mean they're incontinent. So that's going to have to be transferred, transition. Or example, go ahead.
I'll speak for DHAT, which is around at the time, probably about 90 providers. We were doing no telemedicine, and it was remarkable to me in about a week how we pivoted as the pandemic hit to predominantly, kind of along the lines of percentages that Harish quoted, or almost 100%, 80, 90%. I do virtually no telemedicine now. And it's amazing to me, the conversations I have with my colleagues in Texas and across the country, how variable regions are in terms of how much telemedicine they do. For example, I know Ben does a fair amount of telemedicine, or did at the time, and maybe you still do. In the part of DFW where I practice, it's just not what patients want. They want to come in the office. It's interesting to me to see how the patient preferences have driven this. We offer telemedicine options. Patients refuse them. They want to come in person. It's amazing to me, as much of a time saver it is for the patient. Lewis alluded to, I think the biggest rate limiting step was the technical snafus and the ability or sophistication of the patient to be able to handle or get on the system. So patient selection in terms of their ability to be technically savvy to do it, I think is important. Our system was ran through our EMR, and it was crap. It was not stable. Is that fair, Harry? Would you say that? Yeah. And I think we were all resorting to Doxy or and the other, or even WhatsApp because it's HIPAA compliant, as options.
You have a question at the microphone?
All right. I'm Bryce Bush from Brown Rock. Quick question, and I don't know if you guys are doing primarily all ASC, or if you guys are doing some of your cases, especially your higher risk cases in the hospital setting. We talked earlier about delay of care for some of our screening procedures, and I was curious, do you all foresee, now we're trying to catch up with a lot of our cases that have kind of been put on the back burner. Do you foresee any issues down the road with liabilities, patients saying, because we had to put so many things on back burner, this was found later, or could have been caught earlier, and any issues from a liability standpoint?
No. No. It is, it's a COVID pandemic. It is what it is. If you shut down, first of all, if someone would take that case, you've got the best defense. I didn't see anybody. Nobody saw anybody. It's the COVID pandemic. It's a public health emergency. So if somebody would take that case, but I forget which act it is, but one of the acts that I talked about when you start to dig into it, I think it was the Waiver 1135 bill that was passed, but it actually gave, now this is for federally funded Medicare, Medicaid, and CHIP. It protected us from a number of medical legal things, as long as it wasn't healthcare fraud. But you're within what you did. It's not unreasonable. And I've actually seen a couple of patients who had potential delay in diagnosis, but.
Can I ask a follow-up question to that, to Rich? What's the nature of the types of litigation surrounding COVID, regarding physicians and COVID? If I may not be asking the question properly, but I think you get where I'm going.
So that's a great question. I'm having trouble coming up with one because you're protected from HIPAA. So the main, and there actually have been, it's already started, but there was considerable healthcare fraud using telemedicine. So that's an area where services were allegedly provided, but they were not. Upcoding there's one case I just saw, I think out of Michigan, where again, medical supply prescribing like wheelchairs that didn't need to be prescribed, the usual like the DME fraud. But when it comes to like actual civil medical malpractice, I'm not thinking about it. I mean, I could see potentially, like for example, my example. I mean, like I'm like I had the positive result, right? I mean, like it was appendicitis. Like what else could it be, right? You get a CAT scan. It's that Crohn's, gas, or he was constipated. I mean, that was my differential. But I mean, I could see if you could potentially make the wrong call and not tell the patient to go to the ED, and then he has a perforated appendix. But even that, I'm thinking that a jury would kind of like toss a coin. It's tough to say. I've not seen stuff yet, and I've not seen anything in like the medical legal stuff that I read.
I do think that what you said highlights the fact that there's a tremendous amount of volume out there for all of us, and there's got to be opportunities in that as well. So yes, Dr.
If I can, yeah, go ahead.
Yeah. And one other thing, we're still in this, okay? I don't believe that we're post-pandemic, so we're still in this. We don't know how it's going to end. And I'm not talking about, I'm talking about the pandemic, but I'm also talking about medicine, right? We heard it here, transition, right? Transition. Things are ripe. So we don't know how it's going to end. And, just like with the open notes rule, as I presented to you, there's been absolutely no problem that I'm aware of with the open notes rule. We're 6 months into it, okay? And that's not the way the law works, okay? A law gets passed, it makes things happen, and then you see litigation down the pike, a year, 2, 3, 5, 10, to perpetuity later.
And I see David standing. Just one comment. I've seen several people who told me I didn't want to get my scope last year, and then they're coming in with stage 3 colorectal cancer. I just say he felt there was an unavoidable thing. I just write that down there. I'm going to follow up one thing to what Jay and Harish said. I thought it was going to be dreamy, that all of my medication checks for Barrett's and for PPIs and for decipramines and everything, I was just going to have a couple of late afternoons or evenings where I could telehealth all those medication checks. And like you in Bedford and North Arlington, where I have a patient population that averages about 65, none of them wanted to do that once they had the option to come in. So
yeah, that's
dreams
reality.
Dashed.
Yes, Dr. Greenwald.
I'll give you the New York City perspective on some of this. I have like a panel of patients and I'm there in person, and 40 to 70% of them don't want to come. So I sit in an office on a computer talking to them because we've made the time and they don't want to come. So I think the regional variation is really important because colleagues that are working in suburban New York area have more experience like what you're talking about. Everyone wants to come and see them and they don't understand what we're talking about. So I think conversations like this are really good. Second thing, so I have a lot of the patients, they like fled the New York City area. So they go to like Vermont, let's say. And so my office has told, one of them called me up and she said, I just drove 70 miles from Vermont to a parking lot in New York because you're in New York. And, she told me I had to talk to you from New York. So does that make any sense?
No.
No,
because that's your patient.
Yeah.
I mean, you have an established patient.
Yeah.
That's like your patient goes to Florida, right? And they call you up and they say, I'm having really bad reflux. I don't know what to do.
Yeah.
You say, I'm going to call in a script and we're going to double up on
That's
your
all good.
PPI. Yeah. I mean, and then you document it, whatever. Now you could do a telehealth visit even. Yeah. But I don't see that's a problem.
I told her to go back home.
The problem is when you're providing health care to a patient where and their residence is in a different state, okay? Because the anchor is where the patient is, but where you're licensed. So it's where the patient's residence is, okay?
Okay. There's got to be fantastic opportunities in medical practice right now. I know of several that I think are out there. I want to hear what the panel has to say about the biggest opportunities right now for doctors in medical practice. Harish or Jay? No, go ahead, please.
Opportunities in ancillary?
Could be, whatever you think.
So there's big opportunity for GI really is GI, digital GI is going to be very big it's going to be in 5 to 10 years, you'll be doing a lot of IBS management, a lot of that management digitally and not in person. That's one thing is if we don't adopt that, we'll perish. There'll be a problem.
Really?
Yeah. Second big opportunity is in NASH management. That'll be big, which is a chronic care management, which will be NASH and IBD will be the two big ones in that. Third, we're going to have troves of data. Some smart mind needs to figure out, I'm not that smart, to figure that out. How do we really get the value out of that data? Those three in my mind are the big ones.
Dr. Owen?
Harish, I echo that 100%. And when I'm talking about my dream for what I thought my practice will be, you'll see that nationwide. And I think you'll see that where people will be credentialed over state lines. The informatics is huge. We're doing a lot of it right now in GI Alliance, a lot of that driven by Arizona Digestive Asthma. But the other thing, the one in terms of a window opening up and technology and just circumstances is the medical home. And someone who's really comfortable in medical home, they're set.
Can I just go ahead?
There's a couple interesting. Oh, go ahead. Rick.
No.
There's a couple interesting things. I sit on. Thanks to Dave, I sit on the GI Quick board, and a lot of people may not know this. GI Quick's actually expanding beyond endoscopy, and we're going to have guidelines, practice guidelines for chronic conditions, IBD, chronic liver disease, et cetera, based on the certified registry metrics. So I think that's going to be interesting. And it's something our colleagues in cardiology, take care of a lot of chronic conditions, have been doing for a long time, with congestive heart failure, et cetera. So I think that's a real opportunity. We're going to be seeing that develop in GI, and the registry like GI Quick is driving that. The other thing is, and this is a comment again on COVID, is I think we're all seeing the impact of COVID on the inability to retain staff in our practices, and the attrition of staff, MAs, LVNs. And I think that's going to force us to rethink how we run our practices, how we do our patient flow, rooming patients. There's a lot of opportunity for efficiency here. So I think out of this adversity, we may end up developing more efficient practices.
Dr. Moses?
No, I just had a thought, just thinking about the consolidation of practices, but as practices get larger and larger, and I think there's going to be a consolidation of some of these private equity groups. So you're going to get like a mega private equity group. I don't think that consolidation has happened yet, but as more providers in these groups start providing services across state lines, and they get larger, I think that they may become more empowered, and they may be able to, we, the gastroenterologists, may be able to empower some of the state legislators to move forward with parity laws, first of all, where you can be licensed in New York, but then because you're in some large group, even though you're not licensed in New Jersey, provide care in New Jersey, for example. And, if they can get buying power and they can take full risk with insurance companies, if United Health wants you in New York to take care of you in Texas, they have a lot more push than anybody. I mean, let's just call it like it is. So who knows what the next 5 years or 10 years are going to look like.
One of the things about COVID, I'm going to tell you right now, is that it empowered hospitals. The hospital systems profited tremendously during COVID. And your medical practices, no matter where you practice, they're going to become more dependent as gastroenterologists on your relationship with hospital systems and your hospitals. And that varies dramatically in different practices. Some, in fact, even in different pods of some MSOs. The relationship between us, and it's a significant opportunity. So joint ventures, collaboration, better professional service agreements. These are your most important and immediate. They require immediate attention. Does anybody have any comments on that? Or do you agree or disagree with that?
In your region, much different than other region, because if you are a single dominant group in one region and nobody else is there, not even a single other gastroenterologist, you have all the opportunities to have a very profitable PSA. But when there's not that circumstance in other locality, I think it's all regional. It is not, you cannot generalize that.
Well, gastroenterologists, you've heard these stories from Irving Pike in his region and his market. He's very eloquently explained that when gastroenterologists fail to meet the needs of the hospital systems that they work with, that provides opportunities against them. There are many stories like that, and there are many different ways in which gastroenterologists can work together, other than just a monolithic, sort of monopoly, in my opinion. And I just want to point that out. I think that we all talk about the profits that we get from various ancillary services, et cetera, but don't forget to creatively create collaboration with your hospital systems. Any final comments? We're going to finish up in just a second. Please feel free to the effect of challenges of COVID in medical practice right now.
One thing which I'll say with telehealth has also given the opportunity to expand your practices, like what Ben is talking about, whether legally what we can do or not, a different story. But I think once the final telehealth bills will be passed, I think you will have opportunity to practice across state lines. Secondly, which is it gives us opportunity also to provide some service to our patients off hours, which otherwise we cannot, but with telehealth we can.
All right, well, thank you all very much. Appreciate this panel. Look forward to seeing everybody at the celebration in about an hour and a half. Dinner will be served there. Thank you.